Okay, thank you for doing this. Yes, off you go, Laura.
So basically, my name is Laura Gleeson, and I am the Pleural Fellow, who works in Imperial, kind of across Charing Cross and St Mary's mostly, with some interaction with Hammersmith sometimes. And basically, what I'm going to talk to you about today is empyema, which is actually something that we see pretty frequently. It's a very old and well-known medical condition. This is a quote from Hippocrates, circa 400 BC, when he said, "If an empyema does not rupture, death will occur." And this is a picture that I found from a 13th century monk putting a chest drain into somebody's triangle of safety to drain infected empyema. So to start with, I have been advised that a question is sometimes nice. So I thought I would put up this question as we wait for people to kind of join in. So if Karen, are you able to give people the option?
I can put the poll thing up. Yeah, I'll do that now. There we go.
And people, if you want to vote, you can.
Wait a minute.
Okay, you can't vote yet. But this is a 66-year-old man who comes in he's been unwell for 2 weeks. He's got left-sided pleuritic pain. He's short of breath on exertion. He's generally lethargic. This is his X-ray. He's vitally stable. His white cell count is 13. His CRP is 65. And what are you going to do for him? So your options are to refer to the ambulatory pleural service for an aspiration for further investigation, because the hospital is on black alert, as it always seems to be. Or you could perform a therapeutic aspiration for him using a thoracentesis kit as an inpatient. Put in a 12 French chest drain, put in an 18 French chest drain, or just call the surgeons and say, we have someone you need to do a VAX debridement and decortication on right now. So what would your first option be of those things?
Okay, so you can all vote now. And while you're thinking about it, have a look at that chest X-ray. Vital stable. I guess part of the answer depends on how confident you are. Okay, so we have, come on everybody, there's 6 votes so far.
Well, it's only 5 past, so we'll just wait a minute, will we? And see if other people want to join. And this can be their initiation.
We've got 18 participants and...
Oh, 18 participants and only 6 votes? Come on, guys. That's not the participation levels we're looking for.
Okay, we've got 8.
Okay, good. That's better.
Come on, the remaining 10 of you. You just need to move your hand slightly. You don't even need to join Mentimeter for this. You just need to
click the mouse. Nobody's going to call you out at the end and say that you voted for the wrong thing.
Unless you refer to surgeons, in which case we'll know who you are.
No one said that that's the wrong thing.
No.
That might be the right thing.
Okay, let's give it another few more seconds. Okay, and someone's just joined. So if you just joined, we're just voting for what the right answer in this patient who's he's unwell, it says, for 2 weeks, but he's got stable vitals. What will you do with that chest? Okay, shall I share the results then, Laura?
Yeah, sure.
Yeah. Okay. So
yeah, cool.
I'm gonna.
Do I have to stop sharing?
No. I'll just put it on top of everyone's screen. There we are. Waiting for that.
Okay. Very interesting. Let's see what people say when we vote again later.
We can re-ask the same question. 5. The winner is B, inpatient therapeutic aspiration by a very brave doctor. Good. Okay, I'll stop that.
Okay. All right. So what I am going to talk to you about today, if I can get my, is pleural infection. So everybody knows that the pleural space is basically between the visceral and the parietal pleura. The visceral pleura is like a thin layer covering the lung. Parietal pleura is a thin layer covering the inside of the rib cage, and pleural fluid gets produced on a daily basis. And the idea of it is to kind of keep that surface lubricated so that there's no friction when you're breathing in and out. And also because there is a negative pressure between in that space, a kind of a vacuum. It helps keep the lung expanded or pulled up against the rib cage. So when your ribs move out, when you take a breath in, your intercostal muscles move them up and out, and they pull your lungs with them so that air can get sucked in through the mouth. So basically, that's the function of the pleura, but obviously sometimes more pleural fluid than is desirable can be produced. So most or the normal amount of pleural fluid that's produced in a day is about 20 mils in 24 hours, and that just kind of gets absorbed back into the body, and that's a nice steady rate of production and resorption that keeps everything at an even keel. There are many reasons that you can have increased amount of pleural fluid produced, and one of them can be in the setting of infection. So usually when we're talking about pleural infection, we're talking about parapneumonic infection. That's the most common thing that we encounter, specifically as medics. That's the most common thing that we encounter. But there are lots of other reasons you can have pleural infection less commonly. So if somebody has some sort of chest trauma, or if somebody has an iatrogenic a procedure done that causes an iatrogenic infection. So for example, instrumentation where it's not a sterile procedure, you can introduce infection into the pleural space. Esophageal rupture, subdiaphragmatic infections, which can translocate into the pleural space. So somebody who has, a bad cholecystitis or something, you can have bacterial translocation across. Rupture of lung abscess is another one, where you have this dense kind of collection of infection within the lung that then spills out into the pleural space if the visceral pleura is breached. And then septicemia, where you get kind of widespread infection in the blood that then translocates into the pleural space as well. And then we also sometimes see something called primary empyema, where there's no associated pneumonia, but someone just develops an infection in the pleural space. But in terms of parapneumonic effusions, because that's what we generally are encountering, there is a real push to try and classify these into three different types. So simple parapneumonic effusions are in the exudative stage. So they basically are effusions that occur because there's a change in capillary permeability or increased interstitial fluid accumulation due to a pneumonia being present in the lung. And that just causes fluid to leak out into the pleural space. So there's no bacteria in a simple parapneumonic effusion. It's just sort of a sympathetic effusion that appears because there's just more fluid in that area in the lung due to the infection being present and due to this increased permeability of the blood vessels. So it's generally a free-flowing effusion, meaning that it's just a big bucket of fluid that's present. There's no septations dividing it up into different pockets. And you can see in this, can you see my cursor? I'm not sure, but you can see on the figure on the bottom left-hand corner there, that's an ultrasound appearance of a free-flowing, simple appearing effusion, where you can see there's a little kind of tongue of compressed lung because the lung is being squashed down by all the fluid around it. But the fluid looks it looks black, and there is no fibrin threads dividing it up into different pockets. And generally the characteristics of this.
Can I ask about, you've got the pH, glucose and LDH, but you haven't got protein, which is something that we ask the students a lot about. Is that a high protein state, that left one?
Well, so when you talk about protein, what you're talking about, the reason we're always interested in protein is because protein is very important for calculating Light's criteria.
Yes.
And Light's criteria is looking to see if an effusion is a transidate or an exudate.
Yes.
And transidates are commonly caused by things that cause increased fluid retention in the body in general. So heart failure, nephrotic syndrome, liver failure. Whereas exudates are caused by many other things like infection, malignancy, etc.
Yes. So is this an
all parapneumonic effusions will be exudates.
Okay. Thank you.
All of them will have a protein ratio of greater than 0.5. They'll all have an LDH ratio of greater than 0.6. like this is obviously, the rules, obviously you always have some patient that doesn't perfectly follow the rules, but they'll all be exudates, and we're talking about, this is a simple exudate as opposed to a complicated exudate.
Yeah.
But you can assume that they'll all have, none of them will be transidates. That's what we're assuming.
Okay. And the LDH is low though.
So the LDH, so normal LDH in pleural fluid. So if somebody has a transidate, they need to have an LDH in order to fulfill Light's criteria of a transidate. They need to have an LDH greater than 2/3 of the upper limit of normal of the blood LDH. So that's, a transidate has to have an LDH of less than about 160.
Right.
So an LDH greater than that is an exudate. But if the LDH is extremely high, so if it's greater than 1,000, then that's very suggestive that this is a complicated parapneumonic effusion, if that makes sense.
That's really helpful. Thank you.
Yeah. So the LDH, I think including it there probably makes it confusing because it's part of Light's criteria as well. But in this instance, I'm talking about LDH not as part of Light's criteria, but talking about LDH as being really, really high. Like 1,000 is very high. Okay. So and like, a lot of our like malignancy, like exudates, they'll have LDHs of maybe 200, like they won't be like 1,000 is extremely high. So in a simple parapneumonic effusion, it's free flowing, there's no bacteria in it. It will still be kind of proteinaceous type material that's there. So it will still be an exudate, but the pH will be greater than 7.2, the glucose will be greater than 3.3, and the LDH will be less than 1,000. And the pH and glucose, they're both kind of related to the same thing, which I'll talk about in a minute. So they're kind of interchangeable, and you don't necessarily have to send a pH on fluid now. The only value of it is it gives you a result really quickly, which is very good. And so a simple effusion can sometimes respond to just prompt and appropriate antibiotics, and it may not require drainage at all. But this depends on how big the effusion is, because sometimes you'll need to do a drainage. But the people who have like a pneumonia and they have a small parapneumonic effusion, often that is a simple effusion that doesn't require drainage, and the person will get better with just prompt appropriate antibiotics. But it is really important that they get started in antibiotics early and that they're the right antibiotics. The second type is a complicated pleural effusion. And in this one, there is deposition of these loculation, or these septations, which are like fibrin strands that divide the fluid up into different pockets. And you can see the ultrasound appearance there in the middle. You can see that there's black kind of locules of fluid, and between them, there's these fibrin strands dividing it up into different pockets. And when you see that sort of appearance, you're definitely worried this is a complicated effusion and we need to drain it. There may or may not be bacteria present. The pH is going to be lower than 7.2, and the glucose is going to be lower than 3.3. And the reason for that is because at this point you have inflammatory cells in there, plus or minus you have bacteria in there, and those things are metabolizing a lot, and as a result they're producing a lot of carbon dioxide that is making the fluid acidic, and they're also using up a lot of glucose, which is making the glucose low. So that's why you're getting those readings in a complicated effusion, and they need to be drained. If you don't drain that, the person isn't going to get better. And then finally you have an empyema, which is the organizing phase. And at this point, you have pus developing inside the pleural space. You have fibroblasts that are laying down lots of thick fibrinous material. And if you can appreciate on that ultrasound picture there, the fluid pocket, so on the right-hand side of it, you have the liver, and then the fluid pocket that you can see is it looks really dense. It's not free-flowing, and you can see along the line of the pleura. Can you see my cursor, Karen?
Yeah, we can.
So if you see where my cursor is there, that's the pleural surface there. It's really thickened because there's been loads of fibroblasts laying down loads of fibrin there and creating this thick rind. And by the time you get to this stage, it's really going to require a surgeon to go in and peel that away. Although there has been some new developments recently that I'll talk about shortly that may be throwing that into question slightly. But generally, somebody who has this organized type of empyema is going to need surgical decortication, because someone needs to go in there and just peel away everything that's in there. And then a really important thing to remember about this kind of division, to divide things up into these three entities, is they exist on a continuum. So it's not a case that, you know, you definitely 100% fit into one category and that's it. A patient will start with a simple effusion, which will evolve into a complicated effusion, and if left untreated, will evolve into an empyema. So often in practice, you know, you're trying to make an assessment of which category they best fit into so that you can make a good decision about their management. This is just a little bit about the etiology. It's a slide from a Lancet respiratory review looking at pleural disease in 2015, or pleural infection in 2015. And it's just talking about this. What happens here is you've got pneumonia causing inflammation that results in an influx of neutrophils and monocytes into the pleural space. You have like an increase in these pro-inflammatory cytokines in the pleural space, which causes increased permeability, allowing fluid to accumulate first of all, and then that leads to bacteria moving into the pleural space as well. They will stimulate fibrin deposition, causing these septations to develop, and then finally you get this really thick pleural peel that lines the inside of the pleural space and makes it very difficult to treat. And the reason that we're so interested in this division into this simple and complicated and empyema phase is because our management of patients really varies depending on what stage of their pleural infection they're at. So somebody who has a simple effusion, as I said, antibiotics alone can sometimes be okay, but simple drainage may be enough as well. Whereas people who have complicated effusions are going to need drainage at that point and may require further intervention depending on how complicated it has become. While people who have an organized empyema are going to need surgery and possibly a decortication, which involves pulling away that fibrinous peel that's developed. So here's a nice example of a case that we had recently. This is a gentleman who came into hospital, 26-year-old, I think he was. And he basically came in with the X-ray and the CT scan that's on the left-hand side of the screen. And then within a couple of days, well, I think it was about 8 days later, he was on antibiotics, wasn't really improving, rescanned, and within about 8 days later, this was his X-ray and this was his CT scan. So you can see that he came in with a pneumonia and a small, simple parapneumonic effusion, and he was given appropriate antibiotics, and nobody did anything wrong here, but he wasn't responding to therapy, and what was happening was he was basically evolving into a complicated effusion. And you can see that there's kind of this thick rind forming here. And the other interesting thing here is you can see that this is what we call a loculated effusion, which means that it's basically not dependent. So when somebody is lying on their back for a CT, the fluid should obviously fall down with gravity. So you should see the fluid sitting here like it is on the first scan at the back. Whereas in the second scan, his fluid is kind of pasted up into the kind of superior part of his chest. And that's not normal. That means that that's a loculated effusion, and that's a suspicious sign. Oh, so just in terms of epidemiology of pleural infection, it's basically increasing in prevalence, and no one is 100% sure why. So it's increasing in children and it's increasing in adults. One argument or one possibility is that it's related to pneumococcal vaccine, actually, because there's a 7-valent pneumococcal antigen or vaccine introduced in the US in around 2000, and after that they saw a 70% increase in pediatric empyema, and they think it was because they actually selected out some serotypes, by protecting against the more common serotypes that were associated with pneumonia, they actually ended up selecting out different serotypes that are more likely to cause empyemas. So it's very interesting that, you know, actually by preventing one thing, you've allowed a different problem to kind of develop. Obviously in adults, we also have an aging comorbid population with more people using immunosuppressive medications. We've more antibiotic use, we've more antibiotic resistance. And then there's just changes in bacteriology around the world due to increased hospital-acquired infections and things like that, that are contributing as well, probably. But it's something that is interesting because really since the turn of the millennium, or the turn of the century, whatever, there has been this increase in pleural infection that's been noted around the world in loads of different jurisdictions. Risk factors, it's more common in males, it's more common in children and elderly people. And then specific patient-related risk factors are diabetes, immunosuppression, alcoholism, drug use, that's meant to say GORD, sorry, so reflux disease, and then if you have chronic cardiovascular or respiratory disease. And then interestingly, there's been some reports that pre-hospital use of NSAIDs, so someone who has pneumonia and is prescribed an NSAID, that actually increases the risk of developing pleural infection. And then it's definitively been proven that failure to initiate early appropriate antibiotics for pneumonia will or can result in progression to pleural infection. And in terms of the prognosis for pleural infection, it's not great. So in community-acquired cases, the mortality ranges from 7 to 32%. 7% is within kind of clinical trial settings, 7 to 20% has been reported as the mortality rate. But there was a kind of a more real-world review undertaken recently, and they reported a mortality of 32%, which is probably more accurate because trials obviously have a selection criteria, so it's not really a take-all-comers situation. And then higher mortality in hospital-acquired cases, as you'd probably expect. And then really staggeringly, if somebody has pneumonia and they have a parapneumonic effusion, whether it's simple or complicated, there is a 240% increase in their mortality from pneumonia just because they have a parapneumonic effusion. So it's a really serious thing that really doesn't carry a great prognosis. So it's something that we need to work hard on trying to manage properly. And then long-term, about 40% have long-term symptoms afterwards. So bacteriology of it is basically, these are meant to be cartoons reflecting. The first one is meant to be age, the second one is geography, and the third one is patient population. So what I'm trying to say here is the type of bacteria that cause pleural infection will vary depending on your age, depending on where you are in the world, and depending on specific patient risk factors like immunosuppression, etc. So it's really important to know what bacteria are causing pleural infection, because appropriate antibiotics is extremely, it's one of the two prongs of management, as I'll discuss shortly. But actually, less than 60% of aspirates from people who have pleural infection will actually yield a positive culture result. And this is especially true for anaerobic bacteria, which often co-infect in the case of pleural infection. So you may have a pleural infection and you may have a specific organism that you isolate, but oftentimes in about 20% of those cases, there will actually be an anaerobic infection present as well. So it's really important that you have anaerobic cover when you're giving someone antibiotics for pleural infection. The ways that you, as an individual doctor, can help to identify what bug is causing the problem is if you put the pleural fluid into blood culture bottles as well as sending it in a universal container. This increases the yield by about 20%. Also, if you send peripheral blood cultures, because about 14% of people with pleural infection will have positive peripheral blood cultures, so it's really helpful as well. And there's obviously a big interest, and maybe some of you have encountered it in PCR-based methods of identifying what bug is in the fluid, but it's not really endorsed kind of properly yet, because there is a lot of, first of all, detecting PCR of some organism based on the 16S method, first of all, you're not entirely sure what clinical significance that has, because all you've detected is DNA. You don't know that it's viable organism that's in there. But second of all, there's certain bugs that are more readily detectable. So for example, Streptococcus pneumonia is more readily detectable by PCR compared to other organisms. So you don't want to be unfairly selecting out one organism. And that's important for epidemiological studies as well, because we don't want to then think that every empyema is caused by Streptococcus pneumonia, when in fact it's just that we have a test to test for that, and we don't really have a good test for other things. Pleural biopsy can also be used. We don't really use it very often, but it has been used in Imperial on occasion to try and identify an organism. It's really commonly used to detect tuberculosis infection, but we don't really use it commonly for non-tuberculous empyemas. But it's really important to remember with bacteriology that it's different from that of pneumonia, and that you need to make sure you have cover for anaerobes, because they're very commonly co-infected with face. So this is just a little bit about the bacteria that cause it. So this is from two UK-based cohorts that were reported on within the last kind of 20 years. And the most common organism in community-acquired pleural infection is Streptococcus milleri, which is not something that we commonly encounter in pneumonia. So it's interesting because this is different, you know, and it's a viridin strep, so it's an oropharyngeal commensal, but it's actually a facultative anaerobe. So one theory is that actually it thrives in the pleural space, which is, you know, a less oxygenated environment. So it's able to kind of flourish where more common aerobic bacteria like Streptococcus pneumonia isn't as prevalent. Yeah, and then it's in hospital infection, Staphylococcus aureus is a big player, and really keep MRSA obviously in mind, make sure you're giving cover for that. And then depending on where you are in the world, this could vary as well. So for example, in Southeast Asia, Klebsiella is a common contender, in Thailand Burkholderia is. So clinical presentations, it's similar to pneumonia initially, but usually there's a longer duration of symptoms. And you should really be aware that elderly and immunocompromised people can present indolently. So they may not come in with fever, they may not come in with sepsis, they may come in just feeling generally unwell, with a bit of pleuritic chest pain, and, you know, just this smoldering illness for several weeks. And if somebody comes into hospital with pneumonia and you're treating them and they are not responding quickly to antibiotics, then you should re-image them, because that's highly suggestive they may have pleural infection. So there's this paper in 2010 found that if the CRP hasn't fallen by 50% by day 4, then there's a 15-fold increase in the incidence of pleural infection. So you should be seeing that CRP halving within 4 days, and if it hasn't, then you need to be re-x-raying the person and seeing if they have developed parapneumonic effusion. Obviously, bloods, we probably do in every patient. Blood culture is really important, and then imaging. So be aware that a chest X-ray will miss about 10% of pleural effusion, and it will also miss underlying pathologies. So, you know, X-ray is obviously a standard kind of first off the bat method of imaging, but do consider CT scan in somebody who isn't improving despite antibiotics, to see if they have some sort of loculated collection that you can't see on the X-ray. And then ultrasound is also extremely important, and it's the way that we perform pleural aspiration to give us a sample of fluid, which will hopefully let us know whether or not there's concern about pleural infection. This is an example of CT thorax findings. So there's a few different findings that have been kind of put together by Porcel in 2017 that apparently will give a diagnostic accuracy of 81% for pleural infection. So one of them is called the split pleuris sign. So if you see on this top CT, you've got this kind of darker gray, which is pleural fluid, and around it you have this kind of lighter band, and that's the pleura here, and that is called the split pleura sign, because you can actually see the visceral and the parietal pleura separated out from each other. And you can see it's pointed out by arrows on the scan beneath. And it's actually interesting to compare the effusion on the left-hand side in this patient compared to the effusion on the right-hand side. So the one on the left-hand side is bigger, but it actually looks less worrying because it doesn't have this split pleura sign. So you can't see those two bands of lighter gray that suggest inflammatory pleura that has kind of been pushed apart with fluid in the middle. And also you see this little micro bubble here, this little black dot that my cursor is on. So that suggests there's some air in that space as well. And that's a bad sign because air means bacteria is proliferating and producing gas. So they're kind of the things that we look out for on CT. And then, of course, thoracic ultrasound, as I already said, we're looking out for septations. And we're also looking out for that black material, which we would say is it's free flowing and simple appearing. So you'll see it looks a little bit more gray, and you may see like little like kind of gray dots kind of swirling, which is called echogenic swirling. And those that usually means that there's some sort of like proteinaceous material in there, which is obviously a bad sign because it means inflammatory cells are, you know, active and degranulating, and there's fibrin being deposited. So we already kind of spoke about biochemistry parameters that you should be looking at. So pH less than 7.2, glucose less than 3.3. But those two things correlate very closely with each other. So if you know, sometimes people just send a glucose, and that's been kind of supported by the literature, and then the LDH greater than 1,000. Again, remember, it's not that all of these things exist in a continuum. So, you know, it is really important to interpret things, you know, in the context of the patient in front of you. You know, if somebody has one of those parameters is met and the others aren't, you still probably are going to manage it as if it's a complicated effusion. Cell differential is very helpful because if somebody has pleural infection, they'll usually have neutrophilic or an inflammatory white cells in the space. Whereas if someone has lymphocytic cells, then you may need to consider other diagnoses. Maybe it's a malignant effusion, maybe it's a tuberculous effusion. So they're the other things you need to think about. And then microbiology, send a sample in a universal container and in blood culture bottles to increase the yield. And then it's really important as well to know that when you take samples from a loculated effusion like this, you're only sampling one locule usually. So I might sample one locule and the characteristics of it are consistent with a simple effusion, but I don't know what's going on in the locule beside it because I've only sampled one. So generally speaking, the rule of thumb is if you see an ultrasound appearance like this, where there's multiple locules, then you need to put in a chest drain because you need to treat this as if it is a complicated effusion. And then this is a lovely little picture of some pus that was aspirated from pleural space. And obviously, if you see that, you know that you're dealing with something not good. And your biochemistry at that point is just superfluous because you can see with your eyes that this person has pus in their pleural space and it needs to come out. So management of empyemas, two-pronged, antibiotics and drainage. So they're the only two things that you really need to concentrate on, are making sure they're on the right antibiotics and making sure that you've drained it or gotten rid of the infected fluid. And I think that's pretty barn door common sense for any sort of abscess. And that's how I like to think of a pleural infection. It's like an abscess basically inside the patient's pleural space that you need to get rid of the infected fluid that's in there. And then you also need to cover them with antibiotics. So this is a little graph, which is quite interesting, looking at mortality rates from empyema over the course of the 20th and 21st century. So the white block, so the red line is actually influenza mortality, so ignore that. And then the white block is empyema in adults. And you can see at the start of the 20th century, there was pretty high mortality. That was around the time of like the Spanish flu and everything. And then what happened in the mid 20th century is antibiotics appeared. And then suddenly mortality went down, which just shows, you know, sometimes I think we're so complacent about the fact that we live in an era where medicine is just so vastly different to what it must have been like 100 years ago when there was no antibiotics. So generally for treating pleural infection, you need to go broad spectrum, you need to cover anaerobes. There's no real need for a macrolide because atypicals aren't very common. And then you need to consider pleural penetration as well. So for example, aminoglycosides like gentamicin, amikacin generally have quite poor penetration of the pleural space, so they're not really favored. And then when you're choosing your antibiotics, you need to think about, do you think this is community or hospital acquired? Because remember, strep milleri, strep pneumoniae are the most common for community acquired, whereas hospital acquired, you're thinking about Staph aureus. You need to know, do they have MRSA? Do they have any other resistances? And you need to think about what the local microbiology is and what the local resistance patterns are. So obviously talking to your ID or microbiology team is really important. And then the general rule of thumb is to continue antibiotics for 4 weeks. I mean, this isn't very well evidenced, and there was one paper in 2020 that suggested 2 weeks was adequate, but our general way of approaching it doesn't have to be IV the whole time, but you do need 4 weeks of at least oral antibiotics to continue, and that's how things generally are practiced. But maybe that will change in the future. And there had been some conversation around whether or not systemic steroids might be helpful, but the STOP trial was published this year, and there's no role for systemic steroids that was demonstrated with that. So that doesn't look like that's going to change anytime soon. And then the second thing is drainage. So as I said, Hippocrates was the first person, we think, to say if an empyema does not rupture, death will occur. So up until around, well, traditionally this meant open drainage, which basically meant making a hole in the person's chest and just allowing the empyema fluid to just dribble out. So this is a lovely picture at the top of somebody holding a kidney dish underneath somebody's open thoracostomy and allowing pus to drain out of it. And here's a lovely picture of a big hole made in someone's chest to allow pus to drain out. So it's something that is uncommonly used now for chronic empyemas. So this is a CT scan showing somebody who's had, like, obviously part of their rib removed and this hole made in their chest just to allow this giant kind of pleural abscess, I suppose you would call it, allow it to free drainage. And it's interesting because, you know, obviously if you made a hole in a person's chest, normally their lung would just collapse. Because this person has like such a thick pleural rind there, it's obviously just keeping, you know, it's not going to like fall inwards. So it's quite cool what used to be done. But anyway, it was obviously a terrible way to manage it because you were just making a big hole in someone's chest that wasn't sterile, and there was a 70% mortality associated with open drainage, which was used pre-antibiotics as well. But fortunately, in the late 1800s, these two men separately, but around the same time, William Smoult was British, I think, and then this guy, Gotthard Bühler, was German, I think. Both of them separately came up with this idea of the underwater seal. And it's actually exactly what we use today, still most commonly. And the idea of this is you have a drain that comes out of a patient and it goes into water. And then that allows stuff to come out of the chest, but nothing is allowed to go back in. Because, I mean, this is obviously one that's demonstrating a pneumothorax, but the idea of it is it's kind of keeping a sealed system. So you have sterile water down here, so stuff isn't able to go back in through the tube, unlike when you have open drainage, when you've just made a hole in someone's chest. So this really revolutionized the way that we approach drainage of pleural fluid and drainage of pleural infection as well. And it really started to become widespread then around the time of the Spanish flu back in 1918, because there was an increase in pleural infection associated with people who had pneumonia secondary to their flu. So in terms of how you're going to approach drainage, as I said, it depends on the stage of the empyema. So somebody who has a simple effusion, I mean, it may not require drainage, as I said, unless it's large, but that will usually drain quite easily if you put in a narrow bore chest drain and the fluid can just drain out. Someone who has a more complicated effusion, well, maybe, you know, you put a chest drain in and the fluid is too thick or viscous, or maybe those septations are getting in the way. So you may need to, first of all, consider putting in a larger drain. And second of all, you may need to consider the positioning of where you're putting it in. And flushing the drain is really important because, I mean, it's just common sense. If you have a drain that's about the width of my finger and you have really thick fluid with like debris and fibrin and everything in it, then that drain can get blocked off very easily. The little holes in the drain are quite small. So you need to make sure that you're flushing it with saline, keeping that drain patent to allow it to work. And then if someone has a really thick empyema, then perhaps at that point you're going to need something like operation or fibrinolysis, which I'll talk about in a minute. So yeah, drainage, if it's loculated on imaging, if there's frank pus, if the pH is less than 7.2, or the glucose is low, or the LDH is high, if they have a gram stain that's positive or a culture that's positive, or if they have a large simple effusion and they're, you know, symptomatic with it, then drainage can be helpful as well. The way you're going to drain it, there's a few different possibilities. You can use a narrow bore drain or a wide bore drain. So the Seldinger drains that we put in, the standard one that's used is 12 French. That's very thin. You know, that's about the width of a pen. And if you have somebody who has an actual complicated paraneumonic effusion, that's going to get blocked off really easily. So the better thing to do is to put in an 18 French, which is the largest Seldinger drain that we can put in. Above that, you're talking about a surgical drain, which is a whole different ballgame. But I think if you're putting in a drain for someone that you think has pleural infection, then going for the larger drain is a better idea. Really important to be flushing it regularly, as I said, to keep it patent. There's no evidence for suction. Some people do put suction on it to see if they can pull out the pus, but there's no evidence for it in the literature. And I mean, I don't think anecdotally, even I can't say that I've ever seen it working. And then the other thing that's really important is making sure that it's going into the pocket of fluid that you need to get rid of. And the person may need more than one drain. So this is a good CT scan. So in this case, you can see this person has two different pockets of fluid. If I put a drain into this pocket here, I'll drain away this one, but I'm not going to do anything for this one. So you may need to have, you know, a CT scan and really assess, you know, where are the different loculated collections and how are we going to target each one of them. And maybe one of them small and it'll just respond to antibiotic therapy and it won't need to be drained, but you'll only know that over time. In terms of managing a drain, just making sure you know what to do when the drain stops working. So the first thing you need to do is look at the drain, because these are pictures that have been taken on the wards. This is someone who had a chest drain in and it just got completely twisted upon itself. This is, I don't even know what's going on here. I think the drain is migrating out. So it's actually sutured in, but the actual drain is migrating out of the pocket that it's in. So, you know, it's really important to look at it with your own eyes. And it's crazy how someone can be in the hospital for days with a chest drain in and nobody actually looks at it, nurses or doctors. And sometimes it's something so simple. I mean, it's not really, well, I had a gentleman recently who was in, I put a drain in for him on a Wednesday or a Friday. And then the following Wednesday, I got called because the drain wasn't working. It had worked over the weekend and then it had just stopped working around Sunday. And I went up to see him and the drain was actually clamped. Someone had clamped the drain and no one had looked at it. And he'd sat there for 3 days with a foreign body in his thorax, doing nothing for him. So really important that, you know, you look at the drain if you have a patient under your care with a chest drain. And flushing the drain regularly, and then fibrinolysis, as I'll talk to you about in a moment, and then surgery. But the main thing is, if somebody has a chest drain in and it stops working, do something about it. So the point of the drain is just to try and get that fluid out. if it's not working, we need to kind of troubleshoot and figure out how can we get the fluid out. And so fibrinolysis then is basically it's really coming into its own, I think, at the moment. So there's been interest in it since kind of the early noughties, where there was kind of anecdotal case reports and things like that about using urokinase or streptokinase where you inject them in through the drain to break up loculations that are present. And they were reported with variable success, but then in 2005, they did a clinical trial looking at intrapleural streptokinase for pleural infection, and there was no benefit. So everyone was a bit disheartened by that. But then in 2011, they did another clinical trial, and this time they looked at TPA, which is alteplase, which is a direct fibrinolytic. So it's not, streptokinase is a plasminogen activator, so it requires plasminogen activation, which then causes fibrinolysis, whereas this is directly causing fibrinolysis, but also using DNase, which is pulmozyme, which anybody who's worked with, CF patients may be aware of, because we use it to decrease the viscosity of secretions in cystic fibrosis patients. And so it can reduce the viscosity of pleural fluid. And in that trial, people who were treated with TPA DNase combination, only 4% of them went on to get surgery compared to 16% in people who weren't treated like that. And they also had a shorter length of stay in hospital. And this is a graph from that study. So you can see this is the placebo, and this is the change in the size of the pleural effusion that they had. So this is the placebo group, TPA on its own group, DNase in its own group, and then this in the TPA DNase combination group, you can see there was this reduction in terms of the size of the pleural effusion. Usually you will see an increase in pleural fluid production with TPA because it actually stimulates pleural fluid production, but this may actually be part of how it helps the pleural infection to drain, because you're adding kind of more water, so it's becoming easier and more fluid and easier to get it out. And then there's kind of since then been more investigation of kind of how low can we go in terms of the dose of TPA and DNase in order to still have the same effect. So this has been, really quite important, specifically for people who aren't fit for surgery. Now we have a way to try and actually get that fluid out of their space, but it's actually becoming more commonly used in people who are fit for surgery. And during the COVID pandemic, I think it really started to come into its own. And, we have, he's probably not here because he's a surgeon, but one of our new thoracic surgeons was doing a fellowship over in Canada during COVID. And, he said it was extremely commonly used fibrinolysis because they didn't have, theaters were running at half capacity because of COVID restrictions. So they didn't have the facility to be bringing people to hospital or into theater for debridement and decorts. So I think it's something that, we're going to see a lot more of as time goes by. Surgery then, if I have time, I want to show you this lovely video that I have. Okay, actually, I think it's blocked. But anyway, it's just a video of a decortication. It has lovely music with it as well. But it basically involves, usually it's a VATS debridement or decort that is done. So, it's done by a VATS port. And then they go in and they just pull away all those fibrin strands. They drain out the effusion. And then if they need to do a decortication, they just peel away that fibrinous layer that's like, or that rind that's formed inside. So as I said, it's not an easy, so at the moment, fibrinolysis is becoming more and more common. But in terms of fibrinolysis versus surgery, I mean, it's an easy answer when the patient is not fit for surgery, because you're going to try the fibrinolysis, give it a shot. But in people who are young and fit, at the moment, it's more common that we would usually refer them for surgery. That would be the kind of standard way to approach it. If they're not responding to like standard chest drainage. So there are at least three clinical trials underway at the moment comparing fibrinolysis to surgery. So hopefully we'll have an answer in terms of which is the better way to manage someone over time. I know it's quite late, but I do have a couple of cases. Will I keep talking, or well, people can just leave, can't they, if they want to? Is that okay?
No, don't keep talking. You can do. I just want to check. Richard wanted to say something about all your chest X-rays, but Richard was going to say something. He just put something in the chat.
Oh, sorry.
Hi. It was a similar chest X-rays to this one actually that you showed here. It's a point that you might be making in a minute, but
okay, why don't you make the point and then we can discuss it? Would that work?
Yeah, it's just obviously just for everyone to be aware that if you get a chest X-ray that looks like that, clearly there's a left-sided pleural effusion. But the fact that the fluid level is not flat on the left side suggests that this is not just a simple watery fluid in the chest. This is very likely loculated, so there's probably a lot of protein there causing partial tethering of the lung perhaps to the chest wall, which is why you don't get a flat layer there. So that chest X-ray is strongly suggestive of a complicated pleural infection rather than a simple pleural effusion.
Why don't you do one case, Laura? Because we must finish before 2, because people might want to leave. That's true, but they want to hear the end and a conclusion.
Okay. So, well, basically, this is just an example of a 55-year-old man who came in, no background history, no meds, odd cigarette and holidays, fully independent, walks 14 miles a day and swims 3 times a week, and had 2 weeks history of fever, cough, pleuritic pain, had some antibiotics from his GP, didn't work, symptoms got worse, and came in with sepsis and atrial flutter. And you can see that there's one of those pads on his chest, which is always a bad sign in an X-ray. And then, as Richard said correctly, and I think this is the X-ray that I used, wasn't it, for the question at the start? Maybe it wasn't. But anyway, so this, look, it's not dependent. So remember what I was saying about when you're getting a CT scan, the fluid will just fall to the back. In an X-ray, the fluid should fall downwards. So you should have like a relatively straight line across there in a dependent effusion, your little like meniscus and everything. I'm sure everyone remembers from medical school. Whereas this one isn't like that. This fluid is in an abnormal shape. It's not dependent. And that usually is a bad sign. That means this is a loculated effusion. So he had a chest drain put in, and this is also an interesting X-ray because you can see this little patch of air up here, just after the chest drain goes in, which sometimes you could look at that and think, oh, maybe it's a pneumothorax that's been caused by the chest drain going in. But in fact, if you look at his lung is just stuck up in this position because obviously that fluid has been up there, and there is probably a pleural rind starting to form. So as a result, the lung is kind of stuck in that position there, and it's sort of trapped in that position. So you need to give it time for the lung to kind of re-expand as well. So that X-ray again is very suggestive that this person has something like abnormal going on in that space. It's not a simple effusion. So that was day 1, chest drain went in. By day 5, this was his X-ray. So hadn't improved at all, basically. This gentleman was young, well, 55, fit, no background history. So standard management for him would be refer this guy to the surgeons. He clearly has a pleural rind forming. He clearly has, an effusion that isn't improving despite drainage. However, as is common in the current era, he was a COVID contact because he was in hospital, and that interfered with his transfer over to Hammersmith to get his surgery, even though he'd been accepted for surgery. And while we were waiting for all of this to be kind of rectified, he had intrapleural fibrinolysis administered. So this isn't a patient we would usually give fibrinolysis to. This is someone that we were giving it to because the jigs and the reels had interfered with the fact that he was meant to go over to Hammersmith for surgery. And by day 6, we had already started to see a dramatic improvement after administration of just 1 day of fibrinolysis. And by day 10, the effusion was essentially almost completely gone. He obviously still has underlying pneumonia, but the effusion itself is gone. And 1 month later, this is his X-ray. So here's a gentleman who basically completely avoided surgery based on, by giving him fibrinolysis. So it just does raise the question of whether or not, fibrinolysis may have a role to play in these patients. And that's somebody, based on his first X-ray, where you can see this evidence of a pleural rind, probably a trapped lung, that you would definitely be considering surgery for him at early doors. But he did very well with fibrinolysis.
That's great.
Yeah, so you want me to skip the rest of it?
Well,
but anyway,
I think we could do it some other day, because we must finish by 2, because I'm going to do things.
So can I just show you this one though, because I think this is really good. So this is a guy who had a left-sided empyema, and he had a chest drain put into this left-sided empyema. It was confirmed low glucose, high LDH, had a drain put in, fibrinolysis, good response, good output from it, but his CRP was just stuck at 160. And actually what happened was he had this separate pocket of another empyema, and that drain, which had been really good and had gotten rid of most of the fluid, just wasn't accessing that pocket at all. The right side, you see this side? I mean, he has a bigger effusion on that side, but it doesn't have those suspicious features. And that right side was sampled, and it was a simple effusion, and it looked simple on ultrasound. But this left-sided one was complicated, and you can see that split pleural sign. And what we did was drained that pocket, and then he responded. So really important, if someone's not improving, see where is there another pocket somewhere there that you need to access. So this is just some of our pitfalls that I just put in the final slide. Just to say, don't try and manage pleural infection as an outpatient. It's not doable, it's not safe. If you're worried, if someone has an effusion and you think they may have infection, you need to manage them as an inpatient, at least do an aspiration to confirm that they don't have pleural infection. If you're putting in a chest drain, try and put in a biggish one if you can. I mean, this isn't evidence-based. There has been studies done saying small bore chest drains are just as good, but I'm just talking about my own anecdotal experience. If you put in a small one, they often get blocked, and you often need to put in a larger one. And I think sometimes the trials that are done, people are managed in such a micromanaged way, where the flushes are getting done perfectly 3 times a day, and it's not real life experience. And in real life, you need a bigger drain. Don't use a thoracocentesis kit. Don't just drain off 1,000 mils of infected fluid. Put in a proper drain if you're suspecting pleural fluid. If it turns out that it's not a complicated effusion in the end, it's not the end of the world that you put in a drain. You can just take it out again. Send peripheral cultures and send pleural fluid and blood culture bottles. Try and increase the yield so you can pick the right antibiotics for them. If it's not draining, look at it, then flush it, and then do something. So do a CT, see is there another pocket, think about why is this person not getting better. If the patient is getting better, check the drain, check their antibiotics, do a CT, and then do something. And then at the moment, standard of care is still to go with surgery for young, fit people, and earlier the better that you can discuss people. So obviously someone comes in, you're going to put in a chest drain, but you should be thinking about talking to the surgeons within a first day or two, because by the time you get them transferred for surgery and everything, you want to make sure they're aware of it. So then if anybody is still here, here's the question that I asked at the beginning. So if anyone would like to vote again on what they think is the right course for this man. So this is, I think, well, it's actually a slightly different X-ray, but this is a man who's 66, he's been unwell for 2 weeks, he's less pleuritic pain, he's short of breath, lethargic, white cells 13, CRP 65, vitally stable. What are you going to do for him based on what we've just discussed?
Come on, guys, give me 10 seconds. 17 of you, just lean forward and click that button. Okay, 5 seconds. It's good. I can see the answers already. You've done a good job here.
Okay, let's see the answers. Wonderful! Oh my goodness, I'm so delighted. So at the beginning when we asked that question, the majority of people said A or B. And now hopefully we've communicated that this person has an X-ray that's definitely suspicious for pleural infection. Their story is suspicious for pleural infection, even though they don't have rip-roaring sepsis. They have suggestion of infection there. And even if someone isn't rip-roaringly septic, you can't manage pleural infection as an outpatient. So don't refer them to the ambulatory service. Don't just drain off a small amount of fluid for them. You need to get rid of, think of if somebody had an abscess or something, you'd want to get rid of all that infected fluid. You're just making your work harder for yourself. If you just try and target it all with antibiotics alone, get rid of it. If you're going in anyway, you might as well get rid of it. And then you can try a 12 French chest drain, but anecdotally, 18 French is better. And then certainly, it wouldn't be incorrect to say refer to surgeons. I mean, this guy has what looks like quite an organized looking effusion. But the surgeons will tell you to put in a chest drain, obviously. So it's no harm to have them aware of the patient, but yeah, 18 French chest drain, I would say it would be the answer in this question, in this setting. So if anybody has any questions, you can probably email me as the best.
No, they can ask questions now, but that
okay,
was good. Thank you very much. That was really
sorry, I talk a lot.
That's all right. Can I just quickly, I have interested in, you showed us a slide with a nice reduction in death rates over years since we have antibiotics.
Yeah.
And I noticed period 3 looked worse than 1949, which is like now.
Oh, this is the really interesting thing that I was saying earlier. Let me go back to that slide. So the rate of empyema is increasing worldwide. And we're not totally sure on why that is. But if you look in 2000 to 2005, there's an increase in the death rate.
Yes.
And this is, I mean, in this paper, what they were saying was that was where the pneumococcal conjugate vaccine was introduced. So this is this vaccine that it protects against 7 serotypes of strep pneumonia, but it doesn't protect against, I think it's serotype 1 and 3. And those 2 serotypes are the most commonly associated with empyema. So in fact, by introducing a vaccine that protected against other more common serotypes that are more associated with pneumonia commonly, they actually unintentionally perhaps selected, I mean, this is all like just epidemiological evidence, nobody has proved it, but perhaps they like unintentionally selected out these serotypes that can cause this more severe presentation. So yeah, I find that sort of thing really interesting, that like,
well, it's not
the downstream effects you're not expecting,
It's slightly scary because it's higher than 1940, which is just before penicillin came out. So it's quite amazing.
And then, I mean, I guess now we have much more people on immunosuppression, but we also have older people. I mean, probably the life expectancy in 1949 was probably 65 or something,
yes.
Whereas now it's like 85 or something.
True.
So, you have to consider that as well.
Amazing. Well, look, thank you very much. Has anybody else got any questions? Probably not.
I was just going to say thank you very much for Laura for agreeing to do this talk at last minute.
No problem.
I'm taking advantage of her because she's unfortunately leaving us in about 10 days' time. She's missing the homeland too much, I think. But
yeah. Nobody sent any pleural referrals for the next 10 days. Only joking, please send them on.
Yes, good. Thank you very much.
I'll just book them into lists after I leave.
After you're gone.
Yeah.
Okay.
Okay, thanks very much, everybody. And if anyone has any questions, feel free to email.
That's great. Thank you.
Okay.